How was the opening session this morning? What? Well, I don't know. Y'all are going to make me walk up here instead of back here. Okay, so should we get started? I guess. Am I supposed to go ahead and start? How's everyone doing this morning? Good. Great? You said great. I can't hear you. I'm so sorry. Raise your hand. Oh, you said great? You threw your voice all the way up here. That was wonderful. What are your superpowers? So first of all, I'd like to say thank you all for being here. This is pretty exciting because one of my favorite things to do is listen to myself talk. And with COVID, we haven't been doing a lot of presentations, so it's sort of nice to be out. Talking on Zoom only does so much. But what I want to do over the next probably 30 minutes is talk about home as a health hub. But I first want to do it in a larger context. So first of all, a little bit about me. My name is Jordan Asher. I'm the Executive Vice President, Chief Physician Executive for Centera Healthcare. For those of you that know, all of you know Centera is basically a large integrated health system in Virginia and North Carolina. And I am a physician by trade. I'm an internist, hypertension specialist. So as you hear me chatting and discussing, you'll see that sort of clinical perspective layered in. And whether you all think or not, everyone in this group is a clinician of some form or fashion. If you're dealing with housing, as you will see, you are dealing with health. Okay, so thank you as a fellow clinician for all of you that are dealing with health. Because when I say health, that is broader than just healthcare. Healthcare is how do I take care of you when you're sick. Health is your overall scenario. And that's why I like to talk about what we're really talking about at a higher level is a journey of health. And we historically, does anyone in this room wake up in the morning saying, my job today is I'm going to focus completely only on my health? Raise your hand, your wife. Okay. No one wakes up thinking, I'm excited to see Dr. Asher. Okay. Because healthcare is usually in a negative connotation, right? If I'm sick, that's bad. So how do we begin to, instead of having a narrative of failure, talk about a narrative of success? How do we think about it and what does success look like? Which then drives me down to believe, how do we think about adding value to those we serve? Value is quality service and lower cost. Okay, that's the definition of value. individuals and communities. Hi, I'm now tied down to the podium. Let me start all over. No, I'm kidding. And so as we think about this journey, how do we add value? How do we really think about person-centered care, focusing both on individuals and communities? Which then leads us to the next point. I'm a physician. I was trained to diagnose and treat in order to do what? What? To cure, in order to, this is my favorite game. Think what I'm thinking. To prevent death. Okay. What's the opposite of death? No, it's not. The opposite of death is a state of non-death. It's not necessarily life. Life is more holistic. Life is more encompassing. And so we need to think about, as we are going through this journey of health, how do we create life versus just trying to prevent death? Okay? And all of you can think about a situation either in your own family, yourself, or a friend, that it's like, wow, in their attempt to keep someone alive, were they really creating life or were they preventing death? Okay, so success is, how do I give life? How do I create a living situation versus just trying to keep you alive or preventing death? Does that make sense? And if we do that, then we have to focus on more than just the clinical aspect. And we have to focus on your health determinants, of which obviously housing is a major one. And if we do all that, then all of a sudden we've created a healing environment versus just a care environment, where healing is much more encompassing, and thus trying to elevate the joy of what we all do. Now, the reason why I bring this up, because right now, being a physician and a clinician, it's a really tough time with everything that's been going on. And we got to have hope. We have to have resilience. We have to do all this. And part of my thinking is because we think about this story in the negative versus the positive. So as we go on and think about these health determinants, we have to remember, and clinicians don't like to hear this, only 20% of your overall health risks are due to your clinical situation. 80% are due to other factors, whether they be genetic, environmental, with obviously your physical environment being very important. You all know this, but it's important to point out, because in the United States, we have gotten very good at focusing on, from a healthcare perspective, we've gotten very good at focusing on the 20% or the 80%. 20%. There's nowhere in the world I'd rather be acutely ill than the United States. However, I'm not sure if there's a different place I'd rather get old. Okay, because we are very good and very focused on episodic care and getting very good at it, which is at 20% versus the 80% of which housing then fits in. And so I've put this up there. I'm sure everyone has seen this in some form or fashion, which is Maslow's hierarchy of needs. And the reason why I bring this up is because we all try to strive for self-actualization. How do I become the best person I can be? How do I become the best for others? How am I in right relationship with whatever that situation might be? And we have to remember that in order for me to get to that level of self-actualization, there's a pyramid, with the base of it being my physiological needs. And as you can read, and I'm colorblind, so I can't read the black on that. I want to make sure I get them right. The physiologic needs are, I can't even read that. Can someone read them out loud for me? Security, right. So as we think about housing, housing is a basic physiologic need because it's what gives you security, okay? And then if you go up to, if you keep going up, you begin to see where housing fits in,
but housing really is, from the Maslow's hierarchy of needs, it is part of the base of the pyramid. So if we don't think about housing, and as I talk about, housing is more than just do I have a roof over my head. If we don't think about that, we will never get up the pyramid to self-actualization, which is our ultimate goal for every human being. And then on top of this, we have to layer in this concept of health equity. And I want to make sure that we use this as to talk about equality and equity, okay? So this is a picture I love to use, is that equality is on the left, where the goal is, your left, the goal is for all three of those kids to watch the baseball game. I have been given 3 boxes. If I equally distribute the boxes, where before 1 kid was able to watch the game, now how many kids are able to watch the game? 2, okay? These are different heights. However, in an equity model, if I distribute the boxes equitably, all 3 get to watch, even though the taller kid did not get 1 box. And why did the taller kid not get 1 box? They didn't need it, okay? And I'm more focused on the goal, which is to get the kids watching the fence, see over the fence. Liberation becomes when there is no barrier. There is no fence, okay? Wish we were there, but we're not. So we're sort of moving down this, where liberation is there would be no barrier, okay? So we're talking about housing because there's not equal access to housing. So it is a barrier. You can think about that as the wall. Then we begin to think about equality of housing, equity of housing, and at some point, hope maybe liberation. And so going back to the health determinants, if you really think about it, there's 15 categories of health determinants, of which housing, what we're talking about, is residential and community context. And the community context is just as important as the housing. So if I have a roof over my head, which is the base of the pyramid, but if it's in a neighborhood where I can't even go outside, is that a definition of housing, or is that a definition of a roof over my head? And then you begin to think about person segmentation, which don't really worry about. Hey, welcome, come on down up front. My name's Jordan Asher, and I'll start all over. But and you could see the other ones. So as I mentioned before, we were very good at focusing on the disease need processes, but we don't focus on these other ones from a healthcare perspective. So when you come in to see me, and I'm a hypertension specialist, I think of you as a hypertension patient who might have housing issues. Is that the right way to look at it? No, the right way to look at it is saying you are a person with housing issues that happens to have hypertension. And that completely changes the dynamic and the direction we have to think about it, okay? Because you are a human being, therefore I have to think about you within your human needs, that pyramid, versus your clinical situation. Because I guarantee you, if I fixed housing issues across the board, health conditions will improve. Okay, versus me thinking about every single diabetic or hypertensive person and do they have housing or not, okay? And so when you look at just the housing instability, don't worry about the others, the questions really are, do you need assistance to be able to stay in your current housing, or do you need help in finding a place to live that is safe and more stable than where you live now? Because everyone lives somewhere, okay? And so as we think about the questions we need to be asking in every situation, it's really that question that we should be focusing on housing, because it's not only the bricks and mortar, but it's the stability and the safety. And then the second one are the utility needs. If I have housing but no utilities, do I really have housing? Okay, so I wanted to sort of just go through how we think about this from a health determinants. Now, how many of you are from this area? Okay. I wanted just to make a point that housing is health. This is just, don't worry about the details, but this shows you the life expectancy of neighborhoods in this area that are literally right next to each other. Okay, so up in, I believe that's Newport News maybe, or somewhere up on the peninsula, literally next door neighbors. One has a life expectancy of 82.7 years, the other has 68.9. They're right next to each other. You could see it in Portsmouth, you could see the same thing in Hampton, in Norfolk, okay? The point being is that has nothing to do with your clinical situation, because that just wouldn't happen. That you don't have a neighborhood of hypertension. You don't have a neighborhood of diabetes or heart disease. You have a neighborhood of what? People, poor housing, schooling, or whatever those social situations are, okay? And we tend to think about in this country of social situations as different as being about than health situations. They're one and the same. They really are. And you know, obviously evictions are a big issue. Okay, this is data recently that came out of the Virginia pilot, that even though there's supposed to be a moratorium on housing evictions during COVID, you still see these cities that have high rates, or what I would consider high rates of evictions. And that's the rate of eviction of a certain number of housing units. Those red arrows are the cities in this area. So this is national data that's really bringing it to home, okay? And so this is a great quote. Eviction is more than, I didn't memorize it, I'm so sorry. Eviction is so much more than just the loss of one's home. It puts families at risk and makes it that much more difficult to gain your next foothold. The need for more affordable housing units is great, and it will be critical for us to integrate that housing in our communities and surrounding it with supportive services, okay? It's housing, remember I said housing by itself is great, but you need those supporting services, especially as we think about it from a healthcare standpoint. Now, who in here has heard of the concept of patient-centered medical home? Okay, so we have been thinking about this from the healthcare perspective for a while. PCMH, or patient-centered medical homes, have been around since what, the early 2000s, late 1990s. But what's so interesting about the concept of patient-centered medical homes? All great services, but where was the home? My office. How rude is that? Come join my patient-centered medical home, which, by the way, and you get all these wonderful things, but it's my office. Okay, that's the centeredness of how we thought about it. Okay, great services that would wrap around you when you came to me. And where we have really been moving in healthcare is how we flip that on its head as well, where your home should be wherever you are. Okay, now when you are sick, your home might be my office, or might be a hospital, or a place to get chemotherapy, but I should just be a room in your home. I should not be your home. Okay? And so, but we started on this journey. Remember, I talked about a journey of health. I frame everything as evolving and a journey. And so this is where we started a while ago. Now we have really moved into thinking about this, about how do I get into your home, okay? And let me tell you, COVID has really forced us to speed this along. So these are just some of Centera's numbers, where we went from very few telehealth visits to over 120,000 visits. Phone visits, there's lots of ways to communicate. E-visits, electronic visits, e-consults, how do you consult between physicians electronically? And then remote patient monitoring, how do I monitor you at home versus making you come in to get your vital signs checked? So we talked earlier about the importance of your home in your journey to health. Now we're talking about how to move your health care into that home, and some examples of that. Just to give you a sense, this is just some national telehealth data that's coming from the advisory board. And it showed, effectively before the pandemic, how many telehealth visits was the country doing? Not even recognizable. During the pandemic, and it went up to 52%. Now we're beginning to hover around 17% of all visits are telehealth visits. Now, the national average is about 8 to 10 right now. No one knows what the right number is, okay? It's sort of like if you're a surgeon, how many normal appendices did you take out? Well, I took out none normal ones. That means you haven't done enough of them. Well, I took out half of them were normal. Well, that means you're taking out too many. So people used to ask me all the time, Dr. Asher, when do I get to go home from the hospital? And I would say, not a day before you should, nor a day longer. Well, when is that? Not a day too soon, not a day too long, meaning you don't always know the right number. So we're still in our evolution around telehealth, not knowing exactly where this will fall. My guess is somewhere between 15 and 20% of all visits could be done over telehealth, okay? We then, during COVID, really began to say, how do we deal with these issues? And so we began to partner in really unprecedented times. And we did something called a Healthy Hotel Project, which is during COVID, guess what was shut down? Hotels. We had an issue with homelessness. We had an issue with COVID in homelessness. And so we said, okay, well, come on in. We had an issue with homelessness, and we had this extra capacity. And so literally we rented those rooms and made it as a place for homeless that had COVID, okay, that needed a place to recover. We did this with TB in years past. We've done this before. This is not new. What really became new and what became very important was what were those other services that we surrounded these patients with. And so we created preventive services, chronic disease management, just not giving them a place to stay, education, all types of things. And we found all types of clinical issues in these people that we were able to do. And what was interesting is that they became more activated in their care. Why did they become more activated in their care? They had somewhere to stay. Because their main goal every morning was to do what? Find a place to stay. Once I took that issue away, okay, all of a sudden they can become activated to that self-actualization I was talking about. And so this is exactly what we saw happen in our hotel project. And then we are really trying to move care from the hospital to home. And so, so who in here has worked in the hospital business at all, other than me and Dana? Why were hospitals created? Who said I don't know? Okay, call a wingman. You can ask him, phone a friend. Hospitals were created to take care of people where they could not be taken care of anywhere else. Okay? Because 100 years ago, whenever, hospitals were created because there was nowhere else to take care of you when you got that sick. And they were really initially places to go to do what? Die. Okay? They progressed to that scenario. And by the way, who created hospitals at the very beginning? Churches, religious organizations, because they were serving their communities. Communities, you had a bunch of, community hospitals, and you had doctors who, doctors' hospitals, because they needed somewhere to take care of their patients where they couldn't take care of them anywhere else. They were not created as economic engines. Over time, they became economic engines because of our payment models. That's not how hospitals were created, okay? And so what we're watching is an evolution of hospitals where we're now beginning to go back to hospitals just becoming a place to take care of you when I can't take care of you anywhere else. How do I now take care of you in your home? Okay, there's a lot of good with that. And then on the last slide, I'm going to talk about some of the issues with that. And so really a lot of focus on those situations that we can do where we're moving the acute care where we could only take care of you in a hospital and moving it towards your home. It creates better patient care. It helps with health equity. It helps with, it needs infrastructure investments. Operational clinical planning is very difficult, and it takes strategic planning. But the quote, it's really not the hospital of the future is at home. It's that the hospitals will just be relegated back to what they originally were founded to do. Okay, that will be the natural progression as we hope it should be. So we are doing this at Centera. We've been working very hard at it. We're doing it for certain disease states, lung disease, urinary tract infections that require hospitalization, dehydration, pneumonia, heart failure. And guess what? Do you think people like this or don't like it? They like it. They like it a lot. And when you listen to the voices of the consumer, here are some quotes, but the bottom line is they really do like it. Okay. Now, it's very hard to do this on your own, because think about it. It is much easier, just like the patient-centered medical home, it's much easier to bring you to me and do a bunch of stuff to you, right? Hospitals are the same way. It is much easier for me to admit you and take care of you than for me to come to you, because there are a lot of stuff that has to go around. So who's been admitted to the hospital before? Okay, you got to think about everything, your IV fluids, your blood work, your x-rays, what happens if something goes wrong, who's going to take care of you, your nursing, okay? All that has to be solved for if I'm going to take care of you at home, okay? So obviously you need lots of partners to do that. These are just some of the people that we have partnered with to do that. So all I'm saying is that you can't do it alone. Now, I talked about headwinds. Well, I talked about issues, and I want to end before opening up to questions and talk about some headwinds, okay? Because what I just described, both from a housing standpoint and from a healthcare at home, is nirvana, okay? But I want to be a little bit realistic. One of them is connectivity and infrastructure. In order for me to provide care for you at home or education, what do you need? You need broadband. You need tools, okay? I can bring the tools, the connection devices, I can bring them to you, but if I don't have broadband, it doesn't do me any good, okay? So I run the risk of, in fact, by implementing hospital at home type model, I run the risk, because of the broadband and the cost for individuals, families for that, I run the risk of, in fact, worsening health equity issues. Because I can take care of you at home, but you have to have the basic broadband for me to do that, okay? And so as we think about this, we can't think about housing in itself if we're thinking about healthcare. We have to think about housing plus utilities. And guess what a new utility is? Broadband. Okay, because we used to think about utilities as what? Electric, gas, water, sewage. I'll even give you that one. And then came a phone line, right? Okay, you don't need a phone line anymore. You need a cell tower outside your area and or a cable for broadband. Cable TV, I forgot cable TV. That is a utility now, that's a need. Don't even need that anymore. My kids don't, I mean, streaming and everything else. So we have to, so those of us in this housing and healthcare and tying those together, we have to think about that other component of broadband. Staffing, okay? Payment compensation. So for Alzheimer's patients that are cared for at home, what % of that care is delivered by uncompensated family members? 50%, okay? And huge, when they need home care, okay? So a huge amount. Now, what's the problem with that? If I have to impact my ability to have an income to take care of my parents, that creates downstream effects for me and my family, okay? Number two, what if I'm the caregiver for my father, okay, not being a doctor, what am I not trained or good at? Whatever is needed. So when we begin to think about care at home, we also have to think about the compensation and the education and literacy of those people delivering the care. Now, Medicaid, interestingly enough, has thought about this because in some states, they will pay for home caregivers being family members, okay? That's beginning to see how that comes together. However, how many of you have taken care of someone at home when they were sick? Other than getting a discharge instructions from the nurse or from me, the doctor, how many of you were trained or educated at all to do what you were doing? One, maybe two, okay? That's great. But what about the rest of you? How did you all figure it out? You flew by the seats of your pants. Okay, you looked up on the internet if you had broadband. You phoned a friend. Okay, my point being is that we've got to surround, if we're going to do a lot more at home, we got to surround you with that. And then that gets to the last one of health literacy. Okay, patient education. And literacy and education are not the same things. Okay, let's remember that. Literacy, education is a book of material. Literacy is really the understanding. Okay, how literate am I about something versus how educated I am? Because I can get very educated but not be very literate, and vice versa. Patient comfort, mental emotional ease, and then access literacy. And access literacy is if we're going to start taking care of people at home, how do I make sure you know the support that you can get? Access literacy, understanding of what support you might need, whether that be emotional support, physical support. If things are not going well, who do I call? How do I get you to wherever that needs to be? So, healthcare is very difficult to navigate. Does that surprise anybody? And so, because healthcare is complex, but we have to think about how we make it seamless and how we have to move it to the home. So hopefully over the last 30 minutes, exactly, talked about the whole concept of this journey of health, where housing fits into that, defining housing a little bit broader, and then pivoting to talking about healthcare as it relates to the broader picture and housing at home, healthcare at home. Questions? Comments? This could be a conversation. I can't move from this. Yes, and I'll repeat the question for the people that I have no idea are out there. Yes, ma'am.
Okay, I have a comment that each one of your slides, I have a case that came back yesterday, and I am dealing with. First of all, they were living in a summer home, which was their car during the summer. Patient with a chronic illness, genetic chronic illness, so it's not going to go away. They're going to have it all of their lives. So when we talked about in the industry having a medical home, they took it literally. Let me then go to the emergency room, be admitted in the hospital before COVID. It was a good opportunity for them to at least be in shelter.
That's right.
With both of them being able to stay there, COVID hit, then only the patient could go in. So then the other person is back out trying to find housing. We went from then their summer home in their car during the summer to living in the hotel.
Yep.
Which is only for a period of time, because none of us have unlimited monies for them to stay in those kinds of dwellings for any period of time. When the monies ran out, they were back in their car again. I dialed all of the resources that I could find. 211 told us, look out in the rural community. And all of the things that you talked about, no broadband.
Yep.
Getting to the hospital now becomes a trip and journey.
Yeah.
And then we looked at housing in that rural community, which was a better opportunity, I thought. When we found out that the house that they are now living in, and this comes up to the call that I got yesterday, is not fit for dwelling because it is not safe. It is a Florida house with windows that have no insulation in the building whatsoever when you talk about safe housing. So I'm back at the point that I was before with finding this family safe, affordable housing with a chronic illness that's not going to go away.
And a family member that's in and out of the hospital.
Yes.
Okay. And so a couple of key points. I wish I had an answer for you. Okay. Thank you for defining the problem so well. But you brought up a couple of things that I think are very interesting. Number one is that there are a lot of people who correctly have figured out that a hospital is a housing. Okay, so we get admissions a lot, what we call for social reasons. Okay, what other social situation is used that way? Prisons or jails, you know, a cot and three squares. Okay, and so we think about people wanting to not be in the hospital. There are a lot of people that do want to be in the hospital because it's a roof and food. Same thing with jail. Okay, because it's like, oh, I don't want to go to jail. Well, I got nowhere else to go. I mean, you know, let me, and you see that. Now, the problem that creates is that I can't take care of the people that need because I have limited space, and it's not an efficient model. Now, what's very interesting is what children's hospitals has figured this out a little bit, because have any of you dealt or done fundraising with children's hospitals? What do they do, Dana? It's called the Ronald McDonald Houses. Okay, so they saw that because it's kids, right? So when your kid gets admitted, and they're usually at hospitals that people travel to, where do you stay? So they create effectively housing for that situation. And that was that hotel issue. Okay, why did we do that? From a hospital perspective, I mean, it's great for the people, but why did we do that? Forget the cost. During the height of COVID, what did I need more than anything else? I needed beds, space. I was out of room. Okay, and I couldn't let you leave because you had no place to go to get care. But my driving problem was acutely, now it's worked out beautifully, and there's always a burning platform, that I needed beds because we were, hospitals were full. And we were really focused on how do we get people to a different place so I can get that next person in that needs my service. And then we got people to those places and go, oh, that worked pretty well, but they need other services to keep them from coming back and taking up a bed again, which I don't have. And that broke that negative chain. And that's exactly how that's going to have to work, unfortunately. I wish I had a good answer. Yes, ma'am.
You talked about the health hotel project.
Yep.
And how it was successful worked during the time of COVID. What are your thoughts on figuring out ways to continue?
Telehealth? Yeah. So the question is, during a crisis, we used all types of things that we don't use regularly. And how do we continue that? The first question is, how do we continue it, in my mind, if that's how you want it? Okay. Secondly, we have to think about it as a substitution model. So just having telehealth as an addition to my office visit doesn't really help anything. And I think it's both how do we make it easier, and how do we make sure we use it for the appropriate things, and that you are comfortable with it. So for instance, my kid who's 26 would much rather do it that way than go see a doctor in the office. How many of you have used telehealth? Keep your hands up if you liked it better than coming to see me in my office. Okay, some hands went down. My point being is that not everyone likes it the same way. So we would not be consumer centric or patient centric if we said telehealth is for everybody. So we're going to have to go through that segmentation of telehealth is appropriate for what services and what type of people, and then what's their preference. And that's what we're working through right now. So that's why I said that high number at 52% is because you had no other choice. Well, why did it come down to now 17%? Well, it could be because I haven't made it as easy as it could be, and it could be because that's just not what you want, and it might not be for services that were appropriate. Yes, sir.
Other suggestions for the built environment, if you're a developer, if you're building multi-family housing or something like that, certainly you can make sure that all of the units have broadband access.
Yeah.
You could have a station for, telehealth that has super high
Yep,
speed
yep, yep,
and so forth.
yep.
Are there other ideas or do you have a
Yes, so that's exactly right. So the ideas that we are really doing is how do we get into communities that A, how do you provide the basic needs? Okay, and for instance, we've learned a ton with vaccines and testing. And so how do we do vaccinations in areas that would not come out for vaccinations? And if you've been watching the news, we're doing a lot of that. How do we think about housing? How do we work with other organizations to think about what do we put in those places? Now, I'm not saying for Centera as much, but for healthcare systems, we need to be thinking differently because historically, we have really thought about healthcare as how do I take care of you when you need me for your acute illness? Okay, and it's going to have to be a very big paradigm shift to where a health system is thinking about it is how am I coming to you and how am I working on equity and liberation as part of what we are here to do for the overall health of our communities. And it's going to take a different type of financial model. Because right now, for me to deliver care for you, I get paid a certain way. If that definition of care changes and I need to provide it, we need to figure out that payment mechanism. Otherwise, in order for me to do that for you, I got to charge you more, right? Because I got to cost shift because if I build a hotel and do that, if I do all that, that costs money. Happy to do it, but that money has to come from somewhere. And right now, it comes from how much it's costing you, right? That's just the reality of anything. And so then the question really has to be within the context of affordability. So what country spends the most on healthcare? United States. And I'm gonna end on this. What country spends the most on social services? Who said that? Who said it? Guess what country? United States. Who has, for a non-third world country, who has the worst outcomes? The United States. So that tells you something, okay? We spend the most on healthcare. We spend the most on social services. We have the worst outcomes. What does that tell you? It's not working. And why is it not working? It's not for a lack of money. We just haven't figured out how to put it together. Okay, politics, we're gonna get, I'm not going there. Not going there, okay? I've had a great morning, don't make me, But where I wanna leave it on is that we're a country of innovation. We're a country of how do we figure things out. It's really about how do we figure those pieces out together. I said that was my last thing, but you're looking at your phone, that's a bad thing. Yeah, so the question is what resources are available for people in rural areas? So that's the biggest issue. So rural areas, did someone want to answer that, please? None. I was going to say that, it was just going to take me a few more minutes. There are resources. The problem is we don't know how to get to them. Okay, so someone mentioned 211. The thing that we are finding that very impressed with so far is Unite Us. Has anyone worked with Unite Us? That is fair. Anyone here from Unite Us? And how's it been working for you? Yeah. So. And they're now statewide. Yeah. Just launched, I think, like last week. Yeah, so Unite Us, which is under United Way, is basically said, how do because there are a lot of resources out there that are figuring out, trying to find people to help as well. How do I be that match.com for someone just like that person asking the question to go on the Unite Us site, put in location, put in what services you need, and it matches it up. The great, where Unite Us is also going is that it's vetting those places to make sure they're good and can do it, okay? Which then helps lots of us who say, okay, those are the places we should be really working with and investing in to continue to get better. So that is my short answer is 211 and Unite Us. Y'all have a great rest of the conference. Have a great day.